A few years ago, an otherwise sharp 68-year-old patient sat across from me and said something I hear far too often. Doctor, I feel like my mind is slipping, but everyone says it's just aging. What troubled me was not his age, but his medication list, because modern medicine now recognizes an uncomfortable truth. Many cases of memory loss in seniors are not caused by aging or Alzheimer's disease, but by medications that interfere with brain chemistry, blood flow, and neural signaling. Dementia does not usually begin suddenly. It starts subtly with slowed thinking, forgetfulness, confusion, poor attention, and word finding difficulty. Over time, if the underlying cause continues, these changes can become permanent. As a doctor, I want to make this very clear. Medications save lives, and many are essential, but some drugs commonly prescribed to adults over 60 have been consistently linked to cognitive decline and increased dementia risk, especially when used long term. The first and most well-documented group of medications linked to memory impairment are anticholinergic drugs, which include certain allergy medicines, bladder control medications, sleep aids, and older antidepressants. These drugs work by blocking acetylcholine, a neurotransmitter essential for memory, learning, and attention. In fact, acetylcholine deficiency is a hallmark of Alzheimer's disease, which is why many dementia treatments aim to increase acetylcholine levels. Large observational studies published in neurology journals have shown that long-term use of anticholinergic medications is associated with significantly higher dementia risk, and the risk increases with cumulative dose over time. Seniors are particularly vulnerable because acetylcholine levels naturally decline with age, and the aging brain becomes more sensitive to chemical disruption. Common examples include diphenhydramine, found in many sleep and allergy medications, oxybutynin for bladder issues, and some older antidepressants. What makes anticholinergics dangerous is not short-term use, but chronic daily exposure, which silently interferes with memory circuits and accelerates cognitive aging. The second category of medications linked to cognitive decline in seniors is benzodiazepines, commonly prescribed for anxiety, insomnia, and muscle relaxation. Drugs like diazepam, lorazepam, alprazolam, and clonazepam work by enhancing GABA activity in the brain, which suppresses neural firing. While this calming effect may help anxiety or sleep in the short term, long-term use suppresses memory formation, reduces brain plasticity, and interferes with deep restorative sleep stages critical for memory consolidation. Multiple large-scale studies have shown that long-term benzodiazepine use is associated with increased risk of dementia, particularly when used for months or years rather than weeks. In older adults, benzodiazepines also increase fall risk, confusion, daytime sedation, and delirium, which further damages cognitive reserve. The aging brain clears these drugs more slowly, causing accumulation and prolonged effects even at standard doses. The third medication group that deserves serious attention is sleep medications known as Z drugs, such as zolpidem, azopiclone, and zaleplon. These drugs were originally marketed as safer alternatives to benzodiazepines, but research now shows that they also impair memory, attention, and executive function, especially in seniors. Sleep is the brain's housekeeping phase, during which metabolic waste products, including beta amyloid, are cleared. Disrupting natural sleep architecture with sedative medications interferes with this cleaning process. Studies in sleep medicine journals show that chronic use of these medications is associated with increased cognitive impairment, confusion, and nighttime delirium in older adults. Seniors often assume that poor sleep causes memory problems, which is true, but medicated sleep can be just as damaging when it prevents deep, restorative brain activity. The fourth class of medications linked to cognitive decline is certain pain medications, particularly opioids, when used long term. While opioids are essential for acute pain and cancer related pain, chronic use in older adults suppresses brain activity, reduces oxygenation, and alters neurotransmitter balance. Research shows that long term opioid use is associated with impaired attention, slowed thinking, memory deficits, and increased risk of dementia like symptoms. Opioids also worsen sleep quality, reduce physical activity, and increase depression, all of which independently accelerate cognitive decline. In seniors, the brain becomes less resilient to these effects, and even moderate doses can cause persistent fogginess. The fifth and often overlooked category includes some cardiovascular and metabolic medications when overused or improperly dosed, particularly medications that cause frequent low blood pressure or low blood sugar episodes. The brain depends on a steady supply of glucose and oxygen. Repeated episodes of hypotension or hypoglycemia damage brain cells over time. Studies show that recurrent low blood sugar in diabetics is associated with higher dementia risk, and overly aggressive blood pressure lowering in frail seniors may reduce cerebral perfusion. This does not mean these medications are bad, it means they must be carefully individualized in older adults. Cognitive decline often improves when dosing is adjusted to protect brain blood flow. What makes medication-related cognitive decline so dangerous is that it is often mistaken for irreversible dementia. Many seniors are told, "This is just aging," when in fact the brain is being chemically suppressed or deprived of proper circulation. The encouraging truth is that drug-induced cognitive impairment is often partially or fully reversible when identified early. Medical literature documents numerous cases where memory, clarity, and attention improved after medication review and adjustment. This is why geriatric medicine emphasizes regular medication reconciliation after 60. As doctors, we are trained to balance benefits and risks, but systems often fail to reevaluate medications started years earlier. Seniors should never stop medications on their own, but they should feel empowered to ask critical questions. Do I still need this? Is there a safer alternative? Could this affect my memory? Dementia prevention is not only about puzzles and brain games, it is about protecting the brain from unnecessary chemical stress. The aging brain is resilient, but it is also vulnerable. Reducing exposure to medications that interfere with neurotransmitters, sleep architecture, and blood flow preserves cognitive reserve. In summary, the 5 medication categories seniors should carefully review with their doctor are anticholinergic drugs, benzodiazepines, sedative sleep medications, long-term opioid painkillers, and medications that cause frequent low blood pressure or blood sugar episodes. These medications do not guarantee dementia, but they significantly increase risk when used long-term in older adults. Smart medication management is one of the most powerful and overlooked tools for protecting memory after 60.